Good afternoon, everybody, and thanks to AIOS for this opportunity here. So I'll be talking about anti-VEGF injections for ROP, the pearls and pitfalls. So anti-VEGF agents are now being increasingly used in treatment of ROP thanks to these two landmark trials that beat ROP and the Rainbow study, which showed us that for the first time that yes, ROP can regress, vessels can form more than what they were without treating with laser treatment. So yes, obviously people were very excited, and now it is kind of being used as the mainstay of treatment at many places. So I'll just be talking about a few pearls and pitfalls that this approach might have. So the pearls, first, for the giving the injection, the technique that is to be followed for giving the injection in these small babies. So we have to understand that infants are not smaller adults. The eyes are not just smaller in size, they are different anatomically also. So the eyeball is short, yes, the eyeball is about an average of 16 millimeters at the time when we are injecting the child. But the crystalline lens is very thick. It takes up a lot more space in the vitreous cavity than what it would do in an adult. So we have to be careful while going inside the eye. We are more likely to hit the crystalline lens. The pars plana is poorly developed, so we are primarily going to be going in from the pars plicata. So we have to be careful of the distance we are measuring from the limbus to go inside the eye. And the retina could be lifted in some of these eyes, so while entering, the length of the needle and how much we insert the needle could be important, so as not to hit that lifted retina. So where to enter, it's a range that has been shown in various studies, but on an average at the time of 34 to 36 weeks PMA that we are injecting, 1 millimeter is usually a good distance to go inside the eye. You can use transillumination, you want to be more sure about that distance. How to enter is very important. So normally we are trained to aim our needle towards the center of the optic disc. However, in these small children, because the lens takes up a lot more part in the vitreous cavity, you want to be parallel to the visual axis and go straight in so that you don't injure the crystalline lens. Which needle to use is another debate. So 12.7 millimeters 30 gauge needle is what we most commonly use. An insulin syringe has a 8 millimeter needle. Both have the potential to hit the retina on the opposite side if taken fully in. So 4 millimeter needle is what is being recommended nowadays, though the availability of the same is still an issue. What dose to inject? So these are the three main anti-VEGF that we have had experience with: ranibizumab, bevacizumab, and aflibercept in ROP eyes. As a common thing, half dose is what is most commonly used because we don't have doses that are allocated specifically for these small babies. So half dose can be easily made from the volumes that we have, but people have shown effect with even 1/16th or 1/32nd of the dose that we are injecting in adults. So for India, ranibizumab, and all over the world, this is one drug which has FDA as well as DCGI approval. Just a point about the approval: the pre-filled syringe is not approved in India. It is the vial that is approved in India, because from that 0.2 milligrams can be extracted out for injecting. You could inject it anywhere, even in the NICU, in a sterile environment, in your OR and under topical, or in some of the bigger babies under general anesthesia. All you have to do is maintain a sterile field. You should have sets ready for both the eyes, because in the majority of these children we would be injecting both eyes at the same time. So you should have equipment ready for that. And sterile field is most important. I like to drape both the eyes together at the same time, change my gloves in between the two eyes, and then inject the other eye. And I'll just show a small video of the procedure being done. So you put up the speculum in one eye. I put the speculums in both the eyes in one go, so that my gloves are not again and again touching the field. And then the injection, you can see the direction of the needle. This is more vertical than what we would give in adults. Then it's just a small procedure and ended with a drop of betadine and antibiotic. And then you repeat the procedure in the other eye, and then take out the speculum and patch both the eyes with some ointment and antibiotic. The same procedure gets repeated in the other eye. After injection, it is very important to always examine the next day. Look for any drop in media clarity, any signs of lenticular touch. Look for reduction in the plus disease. You can usually see the reduction the very next day. And it is preferable to give topical antibiotics for maybe a week after the injection. Now here is when the main thing of the perils of anti-VEGF start. Giving the injection is very easy, probably easier than what laser would be, but the problems start over here. So local procedure related complications could be cataract, endophthalmitis, hemorrhage, or sometimes even retinal break directly from the needle. Local recurrences are something that we are most troubled about. The recurrence of the disease is very uncertain and it comes in a majority of the cases. Worsening of traction is also a part of the recurrence, and also the long-term neurodevelopmental effects which we still don't have a clarity about. So this is one patient who presented to us with cataract following the anti-VEGF injection, and you can see this needle track, the injection being given directly into the lens, and the hydrodelineation like effect created in the crystalline lens. So you have to be very, very careful about the direction of your needle. Endophthalmitis, because it is an invasive procedure, is another problem. So you have to be careful about the asepsis of the procedure, and especially you are going to be injecting both eyes at the same time. So it has to be very, very carefully monitored, and proper consent should be taken regarding the same. Hemorrhages we see quite often, if sometimes even following laser, because there are pressure changes in the eye that are happening, and these vessels are very fragile at the time that we are injecting them. So yes, while after giving the injection there could be some amount of bleeding from these vessels, and the patient should be counseled accordingly. This was a very unique case where we had a retinal break post injection and was referred to us. It could be because of a direct jet stream injury, it could be because of directly the needle hitting the opposite side, but again another important peril that can happen because of the procedure related complications. The most important part is the recurrences. So, and especially in zone 1 disease, we would see them in almost 70 to 80% of the cases. So our job is not done once we have given the injection. Ideally, you would want to follow up these children every 2 weeks till the point there is a recurrence, and then treat that recurrence appropriately, likely with laser at that point of time. Or you would want to take this baby to about 55 to 60 weeks of post-menstrual age, and then treat that baby at that time under general anesthesia, do a fluorescent angiogram, document the area of avascularity, and treat accordingly. Because in a lot of these babies we see, even when clinically the recurrence is not seen, on angiogram you would see leakage and sometimes subtle neovascularization also. This is a case of a very frank recurrence that occurred at 6 weeks and treated subsequently with laser in this case. Another problem is, because the follow-up becomes so important, if the child is lost to follow-up, there is a problem. So this baby got lost to follow-up due to COVID lockdowns at that point, presented back with tractional retinal detachment in both the eyes. And once this proliferation develops in eyes having given anti-VEGF, it is very tenacious, very difficult to treat in these. Even with surgery, they have a poor prognosis. So this is a safer algorithm that has been proposed by says that use a shorter needle, use proper asepsis, antibiotic and antiseptic. Follow-up is the most important, 2 to 7 days post-injection till the time you are going to see the child. Extra attention to detail, so clean environment, look for conjunctivitis, use of betadine, determine the location that you are going to give the injection, and recheck. Obviously, follow up these patients every 1 to 2 weeks till the point you have a recurrence, and then treat that recurrence. Only then your treatment is complete. Just giving the injection does not complete your treatment. So to conclude, anti-VEGFs for ROP are here to stay. They are not the final answer for ROP, but they are an important addition to our armamentarium, and appropriate consideration to anatomy and technique should be given while administering these injections, and post-term, long-term follow-up is of utmost importance in these babies. Thank you.
Endophthalmitis.
Yes, sir.
And you said special consent should be taken.
Yes.
And you also insisted bilateral simultaneous injection. So that is my concern. And because you said drape both the eyes together, so my concern is only this: first, peril endophthalmitis, special consent. Who on the earth parent will say कि दोनों आँख में इकट्ठा लगा?
So the disease is usually so severe that both the eyes require treatment urgently. You would want to treat them, it is convenient.
I would like to, because I personally am scared honestly speaking, I'm scared.
We are elocuting from the same vial. We are using ranibizumab only. So we are elocuting from the same vial.
So Vishal, you will give bilateral. Any? Denied? You give bilateral. Same vial. Pre-filled injection. Yeah. No, bilateral has a lot of advantages, no doubt about it. But you see, one end of one eye loss means I will never in my life give bilateral. Because this child, you see, who's potentially has to live for 80 years, whatever. You see, how much do you lose by giving a day or two apart?
Yes, sir.
What do you lose by giving day or two day apart?
I didn't get you.
No, why do you give, can you give 1 day, 2 day gap? What's the problem?
So for especially for the babies, there are logistical issues, sir. It is not just taking the baby to the OR and giving the injection. You need monitoring. You need probably a pediatrician or an anesthetist along with.
It's not such a big procedure which we are trying to make. इतना बड़ा काम नहीं है कि पेशेंट को पूरा जिए तो देना नहीं है.
No, sir.
So it's not such a big procedure that we make 2 बार OT लेना है. Compared to if you tell the parents, this thing, क्यों Vinekar?
Sir,
We can debate it. I know it's a debatable point.
our point is most of our patients are the rural patients, so they find it hard to stay in Bangalore for 2 days. But otherwise, I agree that logistically and also the disease sometimes is so bad. Waiting for 2 days, 1 day.
Malika, your opinion? Bilateral simultaneous injections in a child, ROP. Same.
Actually, I don't do ROP, so I cannot say. But I mean, if it's a very severe disease, to give GA again and again is also a problem.
It's just a
No,
mask
but it's a
only.
mask,
It's
no?
a mask only.
It's only a mask.
How
So
much-
anyway, I think I always put it this way, as he said, it's a personal choice. More than scared, I think, in case, I think I have seen bilateral endophthalmitis after bilateral cataract. And I asked the patient also, what's the hurry? So same here, even if it is a rush disease, and I think 2 days waiting, it's better than treating rather than develop.
2 days will not show end off. Sometimes the end off will come after 1 week, 10 days. Then you would have anyway injected bilaterally. But it won't come in 2 days. End off generally doesn't come in 2 days.
No, but either way, it's again a 2 different injections.
yeah,
So
agreed,
you
agreed.
will not have
Yeah, risk reduction is there.
Just because one eye have,
You see,
but
Yeah.
if it is the same
Yeah.
day, because of one eye, you will
Yes,
other eye
yes.
also will have.
We
Risk
all know
reduction
an
is
end
there.
off is early, late, well, that's okay.
But at least, yeah, not the same.
Separate this thing.
Given
No,
the
I know there is a society for bilateral
Yeah,
cataract.
no, I don't do it, yeah.
No, they are doing it. I don't
But
know.
ROP, I just thought that maybe because it's a pediatric situation to give GA again, whatever mask also. Those are the
So given the severity of the
So
disease,
in any
it is
case,
one
we
of
will not take it further. We know it's a controversial. Nobody will.
No,
There
but
may
we
be.
say as a preferable.
Yeah.
Not
Chal,
like our own child we will want to.
yeah. Thanks, Simar, for this